Assalamu alaikum everyone. Am I audible?
Walaikum salam. Yes.
Okay. So I excuse all of you for any background noise because there is some construction going over at my place. And just give me a minute, I would start the presentation. So is my screen visible?
Yes.
Yes, visible.
Okay, let's start. So today is our first session of the Rapid Clinical Review series, and I decided to name the Meningioma series as Simplifying Mefty because the Meningioma series is going to be heavily based on Mefty. And I would recommend all of you to go through the book. It's a beautiful, beautiful book, and it's also written in a very easy to understand manner. So after you are done with the session here, I would highly recommend everyone to go over the text from Mefty because it would correlate better. It would also help you retain. So moving on. We cannot understand tentorial meningiomas until and unless we understand the relevant anatomy. And to understand the relevant anatomy, we need to go over the attachments and the structural relationships of tentorium cerebelli. So yes, Dr. Amir, I'm going to send the Mefty book in PDF on the group, inshallah, so that you can just go over the book. I would send it on the group. So coming back, we are going to start with the attachments and the structural relationships of the tentorium cerebelli. And you would somehow, because the anatomy is going to be microsurgical, I would also mention that why is it important to understand the anatomy in such detail. So moving on, I'm not sure why my screen is not moving. Just give me a minute. So did the slide change at your end?
Yes.
Okay, so moving on. We are going to do the attachments first. Do you have the image of tentorium cerebelli in your head? If you think, then the skull serves as a two-story object. If you imagine the two-story floor plan, you can see that there is a supratentorial or the first floor plan, and then there is the infratentorial or the ground floor plan. And what separates is a roof. The roof is interestingly covering only the posterior fossa, right? So what ends up happening is on the roof of the posterior fossa, there is this dural structure, which we have named the tentorium cerebelli. Posteriorly, it is attached to the transverse ridges of the internal surface of the occipital bone. And why is it important? Because along its attachment of the occipital bone, it's going to separate and enclose the transverse sinuses. Whereas anterolaterally, we see that on the lateral part, there is going to be the petrous part, right? And there it attaches and it also encloses the superior petrosal sinuses. I'm going to show you the images in a minute so that it all becomes easier. Does this image look familiar? You can see the fox cerebri, you can see the tentorium cerebelli here, which has been cut. You can also see the posterior fossa here, and you can see the attachments. Let me draw along that line of attachments. So this is the posterior attachment where it is enclosing the transverse sinus. This is where it is attaching to the superior petrosal ridge and it is enclosing the superior petrosal sinus. And in between, this here is the attachment of the fox. Fox is getting attached to the tentorium cerebelli, and in between this three-layer structure, we have straight sinus here, where my red marker is. And the straight sinus then continues here as the great cerebral vein or the vein of Galen, which is not visible in this image, but we are going to see a lot of images, so it's going to make some sense. And then I come back here. You can see that this tentorium is continuing anteriorly. It continues anteriorly, gets attached to the posterior clinoidal process. It also gets attached to the anterior clinoidal process somewhere around here. You cannot see, you can only see the dorsum sella here. So the posterior clinoidal processes are most likely going to be here. And these are the anterior attachments. These are the lateral attachments here. And these are the posterior attachments. In the midline, there is Fox. I'll go back to this slide so that you can see it more coherently. So we have done the posterior and the lateral attachments. And if we see, just give me a minute, I'll change my pointer. Anterior attachments, I already mentioned that it gets attached to the posterior and the anterior clinoidal processes. Now, this is the straightforward part. It's the easier part of the tentorial attachments. What is slightly difficult is the free margin and the midline structures. So what is the free margin called? I'm going to draw it here, even though there's not a lot of space. You can see that this is a very rough sketch of the skull base. This here is the petrous part. This here is the posterior fossa. We are drawing tentorium cerebelli here. So this free edge is called incisura, the tentorial notch. This is the medial concave border. It's free and it forms an oval opening which serves the passage of the midbrain or the brainstem. So the superior junction and the inferior junction I already mentioned. They come here in between. The superior junction is with the Fox cerebri, and if we imagine this inferiorly, then it continues as Fox cerebelli. Fox cerebelli is just an identical structure like the Fox cerebri. It separates the cerebellar hemispheres. So this is easy, straightforward. You all with me till here? Am I audible?
Yes. Yes.
Okay, so moving on. Coming back to this structure again, you can see that this is Fox cerebelli, right? Let me change the pointer. You can see that this structure is Fox cerebelli. It's same as the Fox cerebri. It's just that it's smaller and does not have as much of clinical consequence, but rest of the structures are pretty visible. The incisura is going to be somewhere around here, right? Why don't we see it? Because the tentorium has been cut, supposing that this is a transtentorial approach. So the incisura is somewhere going to be here. Let me move to the next slide. Okay, so this is a relatively cleaner illustration. Illustrations are always easier to understand because the gross anatomy is obviously not as easy and not as colorful. You can see that this is a tent-like structure which covers the roof of the cerebellum. And in the midline, we have the straight sinus. This is straight sinus that continues like vein of Galen. We can see that there is the transverse sinus. This is the transverse sinus. This is the superior petrosal sinus here. This here is the inferior petrosal sinus. And here we can see the sigmoid sinus, right? So the incisura is this region. This thing is the incisura. And why is it important? Because it's a very congested area with a lot of nerves, a lot of important neurovascular structures that are critical to preserve. We cannot risk not preserving them. So just to go over briefly, you can see what nerves can you see? Can somebody volunteer? This is pretty easy. So what is this structure here? I'll change the pointer. This is trigeminal, right? Fifth. And which is this one? Right along the trigeminal.
Third.
It's the third nerve. It's a third nerve. And then what is this?
Below them, abduce.
Dr. Dimple, please mute yourself. Everybody, please mute yourself unless you are answering the question. So this small region contains a lot of nerves. I am going to make a circle, and there is going to be third nerve, there is going to be fourth nerve, there's going to be the sixth nerve in its Doralow's canal, okay? And there is going to be the fifth nerve. These are the major nerves. You need to remember all of these because I am also going to mention the vessels here. There are some very important vessels running in this congested area. What are these? We have PCOM, right? We have just give me a minute. We have the anterior choroidal artery in this region. We have the PCA in this region. We also have the superior cerebellar artery in this region. And when we talk about the veins, not interiorly, just generally in this region. This is the perimesencephalic region, by the way. So the veins are going to be the basal vein, which are paired. Internal cerebral veins also are associated somewhere here, but they are deeper structures. They are not as easily visible when the basal vein is visible. So then basal veins then drain into the vein of Galen, and then that drains into the straight sinus. So these are three major categories that you should remember. You might be dealing with when we are talking about the tentorial meningioma and the relevant anatomy. Am I making sense so far?
Yes.
Yes.
Okay, so there are a lot of illustrations and dissections ahead for you to make it clear. But before we move on to the tentorial meningiomas, we really need to know what the venous sinus system is, because you cannot understand tentorial meningioma anatomy unless you understand the venous system. So we know that thalamus striate vein and the septal vein somewhere here along the septal vein and the thalamus striate vein at the venous angle form what? What do they form?
Internal cerebral vein.
Cerebral vein.
That's right. And this is called venous angle. Where does this happen?
At
Where's this
foramen of
venous angle?
Monroe.
That's right. This is at foramen of Monroe. So why are we starting here? Because we want to have a very clear imagination of the venous system. So at foramen of Monroe, venous angle forms by the formation of thalamus striate vein and the septal vein. They both simultaneously make this vein. Let me change the color because it's going to blend with the blue. This is the internal cerebral vein. Internal cerebral vein is a paired structure. Always remember this. It's draining from both sides of the thalami and the both sides of the lateral ventricle. So it's a paired structure. What you see is a sagittal section. So both internal cerebral veins then go back and drain into this beautiful vein of Galen. It's a lot more curved in the real life. And here we also have the basal veins, the paired basal veins. Why are they not visible here? Because the basal veins go around the brainstem, as it's very clearly visible from the name as well. The basal veins are around the brainstem. The internal cerebral veins are draining the deeper structures, and both of them combined form the vein of Galen. The vein of Galen then combines with the inferior sagittal sinus and makes straight sinus. Am I clear so far?
Yes.
So this straight sinus goes back. It combines with the transverse sinus. It also joins the superior sagittal sinus. And what do we have here? What's this point called?
Torcular herphyli.
Yes, this is torcular herphyli
Okay.
or the confluence of sinuses. So coming back, thalamus striate vein and the septal vein to the internal cerebral vein. Then we have the vein of Galen. We have the inferior sagittal sinus. They all make up the straight sinus. The straight sinus goes back, joins the transverse and the superior sagittal sinus to make the confluence of sinus. There is occipital sinus below this as well, which also comes and joins the confluence of sinus, but it is not of much significance. So moving on. I've already explained all of this. The origin is, straight sinus origin is at the tentorial apex. It is formed by the junction of the vein of Galen and inferior sagittal sinus. The course is obviously posterior. It runs in the midline junction of the falx cerebri and the tentorium cerebelli. termination is at the torcula, and which is located at the internal occipital protuberance. So at a torcula, or the confluence of sinuses, we have the superior sagittal sinus from above and transverse sinuses on the both sides. Moving on, just give it. So, Dr. Nikat, I think you are drawing on my screen. I have no idea why. So this is another view of the venous system. What do we see here? This is the straight sinus, right? This here is the great vein of Galen. Why does it look so small? Because we are looking at it from above. Usually it's a curved structure and a beautiful, beautiful structure in the middle sagittal section. So these are the internal cerebral veins, and they drain the thalamus, the deeper cortical structures. You can see the basal veins here. They are also paired like all the other major veins. They're also paired. They're going around the midbrain, and they also join the vein of Galen. So moving on. Dr. Jetli, please mute yourself. So this is another structure. You can see the angiography, and this is demonstrating really beautifully all the venous structures. You can see the inferior sagittal sinus here. You can see the vein of Galen here. They are all joining. You can see the internal cerebral vein, and if you look very closely, the internal cerebral veins are paired here, right? And both of them form the vein of Galen. Vein of Galen and inferior sagittal sinus form the straight sinus. You can see that it's going back here. This region is of the torcula. So, divisions of the tentorial incisura. As long as we do not understand the tentorial incisural space and a lot of neurovascular structures that are in such a small place, we cannot operate safely on the tentorial meningiomas. So, this is a small space. I am going to show the illustration I had, but imagine that this is tentorial incisura. This here is the brain stem, very roughly. So this region is the anterior incisural space. Then this region is the middle incisural space. And this here is the posterior incisural space, okay? We have the anterior space, the middle space, and the posterior incisural space. In between is the brain stem, more specifically the midbrain. Let me change the slide. So now you can clearly see that this space majorly is a cisternal space. You can see that this is the anterior. Anterior usually ends around somewhere around here in the dissection models, but this is an illustration, so it's going to be obviously a very rough schematic idea. This here is in between the interpeduncular fossa. I'm sure a lot of you remember the interpeduncular fossa anatomy from yesterday's session by Dr. Itazaz. You can see that we have cranial nerve 3 here. The basilar artery is here, but it's slightly anterior. We are not as concerned with it. But in the anterior space, since basilar is here, cranial nerve 3 is here, and the PCOM is here, anterior choroidal artery is here. Then we have the middle incisural space, which is between the temporal lobe and the cerebral peduncle, mostly, because this is the cerebral peduncle, right? Crus cerebri. And this here is the midbrain. This here is going to be the temporal lobe, along with the free edge of the tentorium. And then we have the posterior incisural space, which is more or less the pinal region. It's going to follow the posterior surface of the midbrain and the tentorial notch here. So we have the anterior incisural space. What are the key structures? Third nerve, basal vein, we have the PCOM and the anterior choroidal artery. Do not worry if you cannot remember it right now. We are going to see them on the images. Third nerve, we already saw its origin. Basal vein is there because I did show you this image, right? You can see that there is this basal vein. Please mute yourself, everybody. It's really distracting, and I end up losing the train of my thought. So this is basal vein. You can see that it's here. Remember this image, and then we come back here. The basal vein, the oculomotor nerve, PCOM is going to be here, and anterior choroidal artery is going to be here. If you remember the course of anterior choroidal artery, you would know that it branches from the ICA and then it courses backwards, right? ICA is here. It branches from the ICA and then it courses backwards along the margin of the brainstem there. What arterial segments are going to be here? Obviously, there was basilar, we could see. Then the basilar is going to be terminated into PCA. So we are going to find P1 and proximal P2 segments. And the superior cerebellar artery, because basilar was there. So the origin of superior cerebellar artery is understandably going to be there. Am I making sense?
Yes.
I will go back to the anatomy here. If you see, this is the basilar artery. We are not concerned with the basilar artery because we are at the topmost section of the brainstem, right? And there's going to be the origin of the superior cerebellar. We are also going to have the P1 of the PCA, proximal segment of P2 as well. We are going to have the PCOM, and then we are going to have the anterior choroidal artery. What are the additional relations? Sometimes it might involve the optic nerve and optic chiasm. Why? Because if you see, there's a lesion here. We can see that it's in close proximity of pituitary, but pituitary is inside the cella, right? So pituitary is not as easily accessible to the lesion. Chiasma is lying on top on the same level, more or less. So chiasma can get involved, optic nerve can get involved, but that is very rare. What is the view? What do you think is this view? Where are we looking at it from?
Anterior.
Anyone? Yes, Dr. Ayman,
Anterior.
excellent. Yes, Dr. Meher, you're right. We are looking at it from the anterior section. If you imagine, you're looking at the brainstem from the front, right? So you can see the basilar artery here, which is then getting divided into its terminal branches, the PCAs. You can see, then you can also see the origin of the superior cerebellar artery here. You can see the crest cerebri, we have the third nerve, and we can also see the PCOM. So this portion is the anterior incisural space. Let me move to the next slide. The middle incisural space is a really interesting area because medially it is bounded by the cerebral peduncle and the upper pons. Let me show you the region here. It's easier to teach on the diagram than on the text. So what do you see here? You can see the cerebral peduncles, right? This here is the peduncles. This is the anterior portion. We are looking at it from the lateral side, and it is more so the view, the anterior view, still anterior and some portion of the lateral view, right? So this is the cerebral peduncle here. This is the cerebral peduncle as well. Then you can see that till here, we are going to have the anterior incisural space. Okay, and from here to here, we are going to have the middle incisural space. The middle incisural space is between, let me change the slide. Do not get overwhelmed by this. This is a beautiful image, but it can be very overwhelming. So let's make it easy. I'm going to go back to the text, but let's learn it on the diagram first. This is the cerebral peduncle, right? This here is the midbrain. What is here? Here is the uncus, okay? And here it's going to be the parahippocampal gyrus. We are on the temporal lobe. You need to imagine this. If you cannot imagine, then it's going to be really difficult to understand the anatomy and hence the surgical approaches. So this here is the uncus. Here we are going to have the parahippocampal gyrus. This is the peduncle. This here is the midbrain. And the in-between space is the middle incisural space. Okay. So now do you have a clear idea of the middle incisural space? We are going to divide it into cisterns till the cerebral peduncles. This is the uncus. This is the cerebral peduncle. In between, what cistern do we have?
Middle interstitial space.
No,
Interpedunclar.
cistern. I'm talking about cistern. Interpeduncular cistern is going to be here, right? This is crura. This is crus cerebri. So what cistern is going to be there?
Crural.
Ambient.
That's right. That's
Ambient.
ambient is going to be slightly
Ambient
posterior.
cisterna.
No. Ambient is going to be slightly posterior. I'm coming to that as well. Let me change the color so that you guys don't confuse it. Coming back. This is uncus. This is cerebral peduncle. Okay. This is midbrain, visible here. This is parahippocampal gyrus here, roughly. And the division is of the cisterns. This is the division. The green portion is the crural cistern. The blue portion is the ambient cistern. Why? Because the crural cistern is between uncus and the cerebral peduncle. I'm sorry, I did not get you. Okay, going back. The green portion is the crural cistern. It is between the uncus and the cerebral peduncle. The blue portion is between the parahippocampal gyrus and the midbrain. That is the ambient cistern. Both of these portions are in the middle incisural space. Most of the crural cistern, and I'm saying for the last time, otherwise I would just have to mute everybody. Please mute yourself. Everybody, please keep yourself muted unless you're answering the questions. So, this portion is the middle incisural space. Understandably, where the posterior incisural space is going to be, even though we are not covering it right now, it's in the next slide. I will just give you a rough idea. This region is the posterior incisural space, and understandably, it is also the pineal region. So when we say the posterior incisural space, what we mean is we are talking about the pineal region as well. Let me go back to the previous slide. Coming back, we know that it is bounded by the cerebral peduncle and pons, upper pons, lower midbrain, sort of. The cisterns are two, crural cistern and the ambient cistern. Crural is between the uncus and the cerebral peduncle. Ambient is slightly posteriorly between the midbrain and the parahippocampal gyrus. What are the contents? The contents are trochlear nerve, anterior choroidal artery, P2 segment of the PCA, superior cerebellar, and the basal vein. So please do not get overwhelmed by this. This is very easy. We knew that PCA was traveling in these systems, right? P1 and proximal P2 was in the anterior incisural space. So obviously the P2 segment of the PCA is going to be in the middle incisural space. SCA is also going to be there. Basal vein is also going to be there, if you all remember the previous anatomy. Trochlear nerve is here because it exits from the surface, from the dorsal surface, and then it courses in the cisterns and it moves anteriorly. Anterior choroidal artery, I already mentioned that it loops backwards. So why is cranial nerve 4 important here? Because it is one of the easiest damaged structures in the transtentorial approach. Let me show you the picture. This is the trochlear nerve. Do you see it's running around the free edge of the tentorial incisura, right? So the free edge of tentorium has two really important structures that can get damaged easily. One is the trochlear nerve, cranial nerve 4. The other is PCA, which is also in close proximity. And why am I mentioning PCA here? Because a lot of you might remember that during severe head injury, if patient has a raised ICP to abnormal levels, PCA infarct can happen because it's getting compressed along the edge of the tent. Moving on to the posterior incisural space. It's going to be a long session because we'll have a lot to cover. So posterior incisural space, primary cistern is quadrigeminal. I already mentioned here, this region here is the quadrigeminal cistern, and it is an extension of ambient cistern in a way. Then we have the vascular content, obviously trunks and branches of the PCA and the SCA because they were continuing. This gets important because in the middle and the anterior incisural space, the main veins were the basal veins, right? But in the posterior incisural space, we have the vein of Galen, which receives both of them, the basal veins and the paired internal cerebral veins. What is the nerve course? Cranial nerve 4 exits below the inferior colliculi. I already mentioned it, that it exits somewhere around here, and then it courses anteriorly like this. So in the posterior space, this is the vein of Galen. This is the basal vein, which is getting combined with the vein of Galen. We can see the fourth nerve, which has been cut here, and the terminal branches of the PCA and the superior cerebellar artery. This is a clearer view. Let me change the color. Vein of Galen, here basal veins, somewhere around here, they also receive the internal cerebral veins. Can any of you tell me the difference between both these surfaces? I'm checking if you're sleeping or actually listening.
One
What is the
anterior
difference?
and one posterior view.
No.
One superior and one inferior. I mean,
That's right. So one is the cerebellar view. That is the superior view. We are looking at it from above. And the other is the inferior view. We are looking at it from below. If you imagine tent, if you're going to look at it from below, you're going to see the occipital lobe, right? Because occipital lobe is above the tent. So this is going to be your view. But if you're looking below the tent, this is going to be the view. This is the cerebellar surface. So here you can see the basal veins. You can also appreciate the superior cerebellar artery. I'm trying to locate the posterior cerebral artery terminal branches somewhere around here. Okay. And fourth nerve exits around here, goes anteriorly like this. This is the fourth nerve. Moving on. We are here on the tentorial blood supply. Why does it matter? So we all know that meningiomas have, we can
Right.
go, sorry. Okay, so we can go for angioembolization in certain types of meningiomas, right? But tentorial meningiomas have no place of angioembolization. Why? Because the tentorial blood supply is mainly from where? It's mainly from the intracavernous ICA. Intracavernous ICA has two major branches, the meningohypophyseal trunk and the inferolateral trunk. Now, it's beyond the scope of this brief session to cover both of these anatomy, but you need to remember that the artery of Bernasconi and Casinari, it originates from meningohypophyseal trunk, and the marginal tentorial artery arises from the inferolateral trunk. Both of these are branches of intracavernous internal carotid artery. And some tentorial branches can originate from the superior cerebellar artery and the posterior cerebral arteries. Obviously, they are in the vicinity. So they somehow think maybe we should also contribute to the blood supply. But this is not the major supply. The major supply still remains from the intracavernous ICA. Hence, there is no role for angioembolization. Classification of the tentorial meningioma. Now, Yesirgil classified them, and then Mefty reclassified them. So we are going to cover the modified Yesirgil classification. Before you remember the numbers, you need to remember the names, and then you need to imagine the names. If your imagination is good, you're going to be a wonderful, wonderful surgeon. This is medial incisural meningioma. I'm going to draw a rough diagram here, even though we have the illustration ahead as well. I'm going to draw a rough diagram. So when we talk about the medial incisural meningiomas, they're somewhere here, right? Because this is incisura, this is the medial portion, medial incisural meningioma is here. So what type of this is going to be? This is going to be T1, T2, okay? Then we have the paramedian intermediate meningioma. What do you think is going to be paramedian here? This, right? This section here is going to be paramedian. Draw this. This is going to be the paramedian region. This is median. This is paramedian, the same as the approach. So the paramedian or the intermediate meningiomas are going to be here. They are T4. Then we have the peritorcular or the torcular meningiomas. Where are those? Very understandable from the name. They are here because the torcula is somewhere around here. So the T5 or the peritorcular meningiomas are going to be here. Then we have T67, the lateral tentorial meningiomas. Very understandable from the name. Lateral tentorial meningiomas means they are going to be around the lateral surface. Where was the lateral surface? It was around the superior petrosal sinus. So this here is going to be the lateral tentorial meningioma. And then we have the focotentorial meningioma. If you all remember, Fox and the tentorium cerebelli had this junction, and in around this junction, anywhere around this line, focotentorial meningiomas can arise. What do we mean by focotentorial? It has dual origin. This is the fold that forms, sort of. This is the fox, this is the tent. So it can arise anywhere here, and it can have dual origin, both from the fox and the tentorial meningiomas. Just give me a minute. So are you with me till this?
Yes.
Yes.
Okay. So coming back, medial incisural meningiomas, T1, T2. Paramedian, when I say the name, try to imagine the location. Paramedian meningiomas, they are T4. When we say T5, they are peritorcular meningiomas. When we say T67, they are lateral tentorial meningiomas around the lateral surface. And when we say T3 or T8, focotentorial meningiomas, they can be anywhere around this line. Moving on, I'll show you the illustration. Okay, so does it make sense now?
Yes.
This is T1, T2. This is T1, T2 is, I'll keep going back to the slide till you all remember this, because tentorial meningiomas, you cannot understand surgical approaches if you do not know the classification.
Median.
Yes, so this is medial incisural meningioma,
Medial and
T1,
superior.
T2, right? This is T67. What meningioma is this?
Paramedian.
No,
Lateral.
it's lateral, it's lateral.
Lateral.
Paramedian is, yes, paramedian is this, T4. You can
T4.
see, okay, if you have difficulty understanding the paramedian meningiomas, you can always think of paramedian suboccipital approach. We are all pretty familiar with it, right? So this is the median suboccipital approach, this is the paramedian suboccipital approach. So understandably, paramedian meningiomas are also going to be slightly off the middle. So this is T4, paramedial. T3, T8, what is this?
Focotentorial.
Focotentorial.
That's right. Brilliant. That's focotentorial. And then we have T5. What is this?
Peritorcular.
Torcular. Yes, it's torcular.
Torcular.
So we have the medial incisural meningiomas, T1, T2. T67 are the lateral tentorial meningiomas. T5 are the torcular meningiomas. T4 are the paramedian or intermediate meningiomas. T3, T8, even though it shows this region, but T3, T8 can be anywhere around here. T3, T8 is the focotentorial meningioma. It has dual origin arising from both the fox and the tent. So I'll move on. What does this show? This shows whether the involvement of the tent is, whether the lesion is only supratentorial, only infratentorial, or it is involving both the compartments. So in the A section, you can see that it's infratentorial. Hence, it is going to involve the cerebral surfaces, etc. If it is more lateral, it's going to involve the CP angle region. You can see that B is supratentorial. It's a tentorial meningioma, but it's supratentorial. Why is it important? Because in this location, it's going to compress temporal lobe and the patient might present with seizures. Then we have the C, which goes both the supratentorial and the infratentorial. So it can present with a very mixed presentation. Patient can have ataxia, patient can have difficulty in walking, patient can also have involvement of fifth nerve, but he can also have seizures. So tentorial meningiomas have a very wide variety of clinical presentation, and it's really, really difficult to diagnose a patient just on the base of a clinical presentation until unless it's pretty typical. If you see the locations here, this is also important because it's going to tell you what the patient is going to present with. T1, T2 are obviously in the anterior and the middle incisural space, so they are going to involve all the structures that we previously studied. What were those? They were the, let me change the color. They were the PCA, the superior cerebellar artery, yeah, cranial nerve 4, also cranial nerve 3 can be involved, 6 can be involved, right? 5th can be involved as well. So when the lesion is here, it's going to have a lot of implications. Then, depending that if it is infratentorial, if it is supratentorial, then it's going to involve the temporal lobe. Why? Because we also saw that anterior and middle incisural spaces were around uncus and the parahippocampal gyruses, right? So the presentation is going to heavily depend on where the lesion is. Whereas if you talk about T6, T7, if they are more or less here around the occipital surface, then they are going to cause compression on the cerebellar hemisphere. The presentation is going to be very different. But if they move towards here, we know that this is the region of CP angle. So the presentation can be very similar to the CP angle lesions. Whereas if we see the T3, T8, now we know that this region here has all the major venous structures. Vein of Galen is here, basal veins are here, internal cerebral veins are also confluencing here. So T3, T8 can present with very different symptoms than T1, T2 or then T6, T7. T5 usually if it is supratentorial, it presents with compression of the occipital lobe. Patient might have visual disturbances, and if it is also going infratentorial, then patient can have ataxia and coordination difficulties. T4 is intermediate. The location is going to decide what kind of symptoms patient have. Infratentorially, it's going to present with cerebellar hemisphere features. Supratentorially, it's going to present with the occipital features. Move on. So the radiology, I'm going to go very briefly through the radiology because we are not left with a lot of time and the radiology is also pretty visible. What do you think this is? Which type is this?
Focotentorial.
That's right. This is focotentorial meningioma. So focotentorial meningiomas were, what type were they?
C to T8.
That's good. I'm really happy that all of you are not sleeping so far. It's a really long session. T3, T8. That's right. So focotentorial meningioma, and it's also going supratentorially, right? So what is the approach going to be? Because the radiology is straightforward, I'm not going to spend a lot of time. What do you think is going to be the ideal surgical approach for this patient?
Midline supratentorial.
Midline supratentorial from where? Any volunteers?
Occipital.
Yes, occipital. What is that called? Occipital
Paramedians of
transtentorial.
occipital.
No. We are not in the posterior fossa. Paramedian suboccipital approach is a posterior fossa approach. We are supratentorial, right? So this is occipital transtentorial approach. We are going through the occipital lobe. Since this is unilateral lesion, we are going to the unilateral craniotomy, and then we are going to go via the fox and the tentorium to resect this completely. Moving on. So when you're looking at the image, you need to think of the easy to approach corridors, because otherwise the imaging is not going to make sense. We all know that how to read this image. This is a hyperintense lesion on the flare image, axial sections. It's a tentorial meningioma causing compression on the cerebral peduncle and the midbrain. I don't want to spend a lot of time in here. What is more important is how are you going to approach this lesion? This is supratentorial. What type is this? And how are you going to approach this? What type is this?
T1 to
T1
T.
That's right. This is T1, T2, which was the medial
Medial incisive.
incisural type, right? Medial incisural type, T1, T2, and it's supratentorial. How do we know that? Because it is compressing what? It's compressing the temporal lobe. Just give me a minute. It's compressing the temporal lobe. This region is of the uncus. This here is the parahippocampal gyrus. It's compressing both of these. So the patient can have memory impairment. The patient can also have seizures. And how are we going to approach this lesion? What are your options?
Diurnal.
Terional. Why terional? Terional, you can, but terional is going to be a really long corridor. You have direct corridors here.
Petrosal
I
approach,
can-
ma'am.
Subtemporal.
Subtemporal approach. Just give me a minute. We are going to go subtemporally. Why? Because the lesion is not of temporal lobe. The lesion is of tent, right? This means that it is sitting below the temporal lobe. It might be displacing it above, it might be pushing it, but the lesion is sitting below or at the level of the temporal lobe. If you go via the subtemporal approach, you can just retract the temporal lobe, you can go beneath it and easily approach the lesion. Let me clear this. Moving on to the next image. Okay, so what type is this?
Lateral. Lateral.
Lateral.
That's right, this is lateral. And yes, which one?
T78.
T67. This is
Sorry.
T67. T3 and T8 were here. T3 and T8 are a pair. T6 and T7 are a pair, right? So this is T6, T7. It's a lateral meningioma. You can see that it's arising where? It's arising from the occipital surface of the tent. It might involve the which sinus? You can see that the sinus
Transverse
is not
sinus.
visible.
Transverse.
That's right. You can already see that the sinus is not as visible here. And this is transverse sinus. It's also reaching up to the CP angle, but not going in there. There's significant amount of compression on the cerebellar hemispheres, but it's far from the brainstem. So how are you going to approach this patient?
Suboccipital.
Suboccipital where?
Lateral.
Okay, can we go via retrosigmoid?
Yes, ma'am.
Yes.
Because if you go through paramedian, you're going to land here. If we go through retrosigmoid, we can use this corridor, and it would be accompanied with a lot of less morbidity here. Let me change the slide. So what is this? It's a supra-infra both. Supra-infratentorial meningioma?
Sobra.
Yes. And what type is this?
T3 to T8. Falco
T3,
tentorium.
T8. It's not T3 to T8 because that would imply T3, T4, T5, T6, T7, T8. It's T3 and T8. So they are the
Okay.
only types. They're a pair. T3, T8. It's Falco-tentorial. Brilliant. So, Dr. Marvin, please mute yourself. So tentorial, and this is both the supra and the infra. How are you going to decide a surgical approach, and what is one deciding factor that is going to determine whether you are going through here or whether you're going through here?
Sinus involvement.
Madam's
sinus
intracerebral vein involvement.
No. You're close, but not too close. What are the two approaches that you can think of?
Transtentorial.
Tentorial supracerebellar approach and
Supracerebellar
Okay.
and transtentorial.
Okay. So please mute yourself. So if I say that here is the vein of Galen, would you still go supracerebellar intratentorial?
No.
the
No.
tentorium is steep,
If
then we go
if
occipital.
No.
yes, if the vein of Galen is displaced upwards, then
Then we approach from below side,
that's
infratentorially.
right. So apart from the location, we are going to that slide as well. Apart from the location, one thing that determines where you are going to approach the lesion, whether supratentorially or the infratentorially, is the location of Galenic vascular system, Galenic venous system. If the vein of Galen is displaced superiorly, you can approach it from the infratentorial approaches. If the vein of Galen is displaced inferiorly, you are going to approach it from the supratentorial side, because you cannot risk vein of Galen injury. It's going to lead to catastrophic infarction. So this is really easy. I'm not going to spend a lot of time on it. What type is this? What type is this?
The medium. Lateral.
Lateral.
This is lateral. This is not paramedian. Paramedian would be here. Paramedian is not as common, and it would be somewhere around here. If you see it on the coronal section, it would be here. Okay, this is the tent. Paramedian would be somewhere around here. This is lateral, more moving towards the CP angle. It can be confused for petroclival meningioma as well, or CP angle meningioma as well. But we see on the coronal sections and the sagittal sections whether the tentorial attachment is enhancing more, and that tells us, and where the dural tail is pointing, that tells us where the origin is. So this is a lateral T6, T7. Meningioma, where are you going to approach it from? What is the corridor?
Retrosigmoid.
Retrosigmoid. Brilliant. Moving on. I think you're all pretty clear with the classification and the approaches, because rest of the presentation is really, really easy if you have paid attention to whatever we discussed previously. There is a myriad of signs and symptoms for tentorial meningiomas. They can present from headache, dizziness, gait disturbance if cerebellar hemispheres are involved, mental status changes. Why? Because if there is compression on the midbrain, RAS is going to get compressed, reticular activating system. That is going to lead to altered level of consciousness. Visual disturbance can be there. Hearing impairment can be there due to cranial nerve eighth involvement in the CP angle. Why seizures? If it is supratentorial, then the temporal lobe involvement. Yes, hemiparesis. Why? Because cerebral peduncle is there. Trigeminal neuralgia. Why? Because cranial nerve 5 is there. Hemihypoesthesia, obviously due to 5. Tinnitus, dysphagia. Dysphagia is very rare until and unless it's a lateral meningioma, and then it's growing downwards, involving the lateral canal nerves as well, which is very rare. So if you remember the locations and the types, the presentation is not going to be a difficult portion for you. These are the signs: gait ataxia, multiple cranial nerve deficits, hemiparesis can be there, homonymous hemianopsia can be there. Why homonymous hemianopsia? This is a
Occipital lobe.
supratentorial. Yes, this is supratentorial occipital lesion. Hemihypoesthesia, aphasia, we can have incidental finding as well. Let me move on to the next slide. What are the investigations? There are only 3 investigations. MRI brain with the contrast. We are going to need an MRV to delineate the sinuses, whether they are patent or not, whether they are involved or not. Very rarely catheter angiography, especially if torcula is involved and we want pinpoint venous localization. CT brain is usually not indicated. And as I've mentioned previously, there is no role of angioembolization in these patients. Surgical approaches. Surgical approaches are not going to be difficult for all of you, since you have paid a lot of attention in the previous slides. T1, T2, Incisural. Do you remember where that was? Right? This here
Medial.
was the T1, T2. Yes, medial incisural meningiomas. If they are infratentorial, we are going to go via either retrosigmoid approach or via superior cerebellar infratentorial approach. Both are relatively long corridors, but we can go via it. If they are supratentorial, we are going to go subtemporal, right? If they are supra-infratentorial both, then we can go via presigmoid approach, which is also a modification of posterior petrosal approach. So Dr. Mustafa, I think you said we can go via petrosal approach. We can, if it is a lesion which is involving both surfaces, the supra and the infratentorial both. So T3, T8, focotentorial, they are in the midline. Let me draw here. This is the midline. They are somewhere along here. If they are supratentorial, involving both the occipital lobes, then we are going via bioccipital interhemispheric approaches. Tick. If it is supra-infratentorial, let's do the infratentorial first so that it does not confuse you. If it is infratentorial, then we are going to go via supracerebellar infratentorial approach. Okay. If it is a lesion where it's supra-infratentorial both, then we have this option of going occipital transtentorial. We go via the occipital approach. I have a picture ahead. We go via the occipital approach, and then we have this option of transecting the tent and going below the tent in the infratentorial compartment. So, what is this type? This is T1, T2, medial incisural. We are going through. Here we can go via the retrosigmoid approach. We can also go via the superior cerebellar, but I personally find that corridor very long. Retrosigmoid, I think, would work perfectly fine here. And this here is the supratentorial T1, T2 variant. Why? Because we can see the temporal lobes here. We can go subtemporally here. That's right. So these are all some other images of the same case. There's another important thing. The first approach, the first surgery is the best surgery. Why? Because the arachnoidal layers are preserved. And why are they important? They are important because all these structures, the neurovascular structures, are in their own layer of arachnoid. So if you're doing microneurosurgery and if you're respecting the arachnoidal boundaries, it might be possible to achieve gross total resection or at least near total resection. If you're not going to respect the arachnoidal membranes that are around the neurovascular structures, then it would be very difficult for you to find a plane. So that is why first surgery is the best shot at getting it out, because in the consequent surgeries, in the consecutive surgeries, you are not going to find preserved arachnoidal planes. So what type is this? This is sagittal section, so you might find it slightly difficult. But what type is this?
T1, T2.
Neutral.
Medium.
No. It's focotentorial. Excellent, Dr. Meher. You can see that it's here in the midline. It's a mid-sagittal section here. It's originating from both the fox and the tentorium cerebelli. It's also compressing the cerebellar hemisphere. So these are T3. T8 are somewhere around here as well. How do we approach them? We have already discussed two approaches, occipital transtentorial and supracerebellar infratentorial. What determines the approach? First, the lesion location, then the vein of Galen. Yes, a vein of Galen location. Moving on. T4, paramedian. We are going to go via supracerebellar infratentorial on the unilateral side. I will just draw here roughly so that you don't end up forgetting. Some of you are confusing the paramedian still. This is the incisura, this is the midline. Paramedian are going to be here. If it is infratentorial, which it most likely is, we go via supracerebellar infratentorial approach. T5 or the peritrocular, they are here. We have two options. I've already discussed them. Infratentorial, we can go by occipital approach or suboccipital. And then we transect the tent. If you do not transect the tent, A, you cannot achieve a complete resection. B, you cannot approach the other side of the lesion, because this lesion is going to involve two compartments. So incising the tent is going to be a necessity for this. And what do we need to take care of when we are incising the tent? Cranial nerve 4. Okay, so infratentorial, peritrocular, it's very easy, supracerebellar infratentorial approach. Are you all with me? We are very near the end almost. So you can see different locations of the tentorial meningiomas here. These are the focotentorial. You can go posterior interhemispheric. You can go occipital transtentorial. This is the supratentorial suboccipital approach or infratentorial supracerebellar approach. Wherever we go from, we are going to transect the tent and approach the lesion, which is above or below the compartment. This is the paramedian meningiomas. We go via supracerebellar infratentorial approach. This is lateral. We can go via retrosigmoid approach. Here, yes, FTOZ can be used. Subtemporal approach can also be used, depending on the exact location of the lesion and the structures it is involving. This is an image of occipital transtentorial approach. You can see that we are creating a craniotomy on one side using a hinge flap. And when we retract the occipital lobe, we are going to see the tentorial surface and the lesion. This approach can be used for focotentorial meningiomas as well. And it can also be used for torcular if the involvement is more on the unilateral side. So you can see that they have incised a tent here and the infratentorial section of the lesion is visible. But this is associated with a lot of morbidity. If we end up retracting occipital lobe too much, patient might have visual deficits. T67, lateral. We have already covered retrosigmoid, supracerebellar infratentorial, and subtemporal if it is above the tent. For Fox cerebelli, supracerebellar infratentorial is another approach. We have already discussed this. What decides supra versus infratentorial approach apart from the location? That is Galenic venous system. If vein of Galen is displaced superiorly, we will go infratentorially via supracerebellar infratentorial approach. If vein of Galen is displaced inferiorly, we will go supratentorially via occipital transtentorial approach. And that's a wrap of a really, really long session. Any feedback, any questions, they're all welcome. I would not be able to take them now, but you can always leave them on the group and I'll come back to it, inshallah. So I'm just going a disclaimer. Sessions from now on are going to be slightly longer because it's a lot of information to be condensed in one single class, but I tried to do my best. So thank you so much, everyone. That's a wrap for today. All the feedback is welcome. Please leave me some feedback or any questions that you have on the group. Thank you.
Thank you, Jazakallah.
Thank you so much. Have a good day or a good evening from wherever you're listening. That's a wrap.